Our next speaker is Catherine Malherbe. She has a free paper which she's presenting on an artificial intelligence point-of-care ultrasound or Pocus breast cancer screening program in Gauteng, improvement of patient referral pathway program.
Thank you. All right, good day everyone. My name is Catherine Malherbe and I am presenting an AI point-of-care ultrasound, more commonly termed Pocus, breast screening program in Gauteng. A few disclaimers: the study is currently funded by the AstraZeneca A-Catalyst network, has received ethical clearance, and the algorithm currently being used is ZA patented. If the war against breast cancer seems like an unending series of misguided schemes and false hope, much like our ongoing wars against terrorism, drugs, and poverty, it's because, like those wars, the enemy, breast cancer, has never been just one monolithic opponent that can be fought with one kind of weapon. The current medical era has allowed many activists of the disease to propose new advances and hope for the fight against breast cancer. The statistics surrounding breast cancer is well known. However, recent literature has suggested the method of clinical downstaging, where the earlier detection of breast cancer focuses on those that are symptomatic women to promote overall improvement of patient prognosis. This approach contrasts with population-based opportunistic screening, which focuses on asymptomatic women. Clinical downstaging is suggested specifically for countries like sub-Saharan Africa, where late-stage breast disease is well known. The key focus for clinical downstaging is employing education of healthcare workers and the public to promote earlier detection and improve the patient referral mechanisms and access to treatment. There is strong evidence that a delay from symptom recognition to diagnosis is more than 3 months. Specifically in South Africa, the time interval from symptom recognition to diagnosis is often over 6 months. These long delays are consistent with breast cancers comprising of predominantly slow-growing, less aggressive, estrogen receptor positive subtypes. Along with the literature, it is well known the most cost-effective and easy method of early detection is through education of the public in BSE and also for the healthcare professionals in CBE. However, recent studies have shown an increased efficacy, especially in rural setting, with the conjoint use of point-of-care ultrasound along with AI. The study that we are currently running at Dustwood Polyclinic in Pretoria West consisted of initial 2 months training on the clinical site on breast AI, CBE, and also the point-of-care ultrasound for the on-site general practitioner and registered nurses to be used as a screening tool during their standard clinical practice. A community healthcare worker was also deployed to educate communities in rural Malusi village, and there are also dedicated referral task teams at the breast clinic or surgery centers of Kalafang, Tembisa, and Baragwanath. Patients that were included were between the age group of 25 to 85 years, with or without a clinical history, and the use of the Pocus breast eye basically is used to allow the sifting of the general population so that only targeted patients are referred into the public healthcare system. This makes a dramatic reduction in the burden and overload currently in our public sector. The artificial neural networking system that is being used, it contained dataset training and validation of over 40,000 histologically confirmed breast cancers using only B-mode ultrasound. This system is able to discern between high-grade, low-grade breast cancers and ductal and lobular carcinoma on-site through the sole use of breast ultrasound. One of the initial studies that was done through the 3 years of research and development of this AI system is that it was able to have an accuracy rate of 95% for being able to pick up lobular carcinomas on B-mode ultrasound, as we all know is quite renowned to be easily missed on imaging. Currently, the results of the study, month 1, has been finished at the clinic, and the impact that it has made is quite vast. The community healthcare worker has educated over 600 women in the Malusi village. Almost 200 women have been screened from the nearby surrounding regions. 5 have been referred for short-term follow-up, of which 2 had callbacks, and the AI confirmed that it was a low risk for malignancy. Other rural outreaches have also been done to Unjani clinics in the Soweto, Lufereng, and Clayville regions. The best impact that we noted from this, as a previous speaker had mentioned, is that we are not working in silos. Typically, the diagnostic and therapeutic centers are working in separate silos, but through the conjoint use from points of education to the actual on-site diagnosis and referral pathways, we've been able to reduce the time of patient referral, which was typically 6 months, to be fast-tracked within 1 week for surgical intervention. It's always interesting to include a picture for all the radiologists out there. So this was specifically a patient. She had been on the waiting list at a regional hospital for 3 years for surgical removal of a phyllodes tumor. The breast AI picked up a low risk for malignancy, but it has to be known that phyllodes tumors, although they are very rare fibroepithelial neoplasms, there is up to a 30% risk of it developing metastatic disease. My talk is short and sweet. So there's definitely a need for education of patients alongside the diagnostic and therapeutic interventions, and it is quite evident that the method of clinical downstaging might be a key factor in assisting in the overload of patients being referred to regional hospitals. Thank you so much. I'm sure there's questions from radiologists.
Thank you very much for that excellent talk. Yes, Francois? Oh, Justus?
Oh, okay, great. Oh, okay, wonderful. That makes me more at ease.
So, I mean, I think this is excellent. This is very good for South Africa. We don't need mammography in this country. Screening mammography leads to too much overdiagnosis. And we can't manage that overdiagnosis. It's impossible. I mean, maybe in the private sector, but in the government sector, yes, it's never going to happen. Mm-hmm. So I don't have a question, but a comment. And, you know, I think you're doing great work. And this is what we need. And we need buy-in from government to help us with this. I mean, we've been using bedside ultrasound in our clinic at Groote Schuur. And, you know, our waiting times for patients waiting for radiologists to do their ultrasounds came down from 52 weeks, which was a year, to 2 weeks since we're doing most of the ultrasounds ourselves. Yeah. And you know, it's helped us tremendously to just, you know, fast track the masses to decide which ones do we really need to worry about and which ones, you know, can go through the system much more slower.
Yes, and that's exactly why it's targeted in more rural setting. The Malusi village specifically has hundreds of thousands of women that have never seen the inside of a clinic, and now for the first time they're actually getting education and also the screening. But disclaimer for the radiologist, it's not reinventing the wheel. Mammography remains the gold standard. So if any patient is picked up as a high risk for malignancy, they'll still be referred into the system for the standard histology and such, but it helps the nurses on site to be more targeted and more assertive, so that when they're referred to the surgeon, he already has a very good idea or prediction of what needs to be done next. Yeah.
Yes. I have many comments to make, but I want to make only one. Okay. Our problem is not screening. And I think you don't understand what screening actually means. Screening means the examination of a totally asymptomatic woman with some form of investigation where there's no evidence of disease on a clinical grounds. In most of the developing world, and I've been deeply involved in that, the problem is that women that arrive with a lump do not get a biopsy, and that's the standard. And that is the challenge that we have. And we know in the Western Cape, as it was pointed out, waiting times before start of treatment was 6 months. Yeah. And that is the problem. not the screening.
No.
It
no.
is the referral of clinically symptomatic women who seek health.
Yes.
And for that, in actual fact, we don't need radiologists. We need clinic nurses that can do an ultrasound and a biopsy, and we must pick out those nurses and actually educate them. We are beholden often to monopolies on professional activities. And if anybody is interested in that, I only recommend studies of Indian institutions like the eye clinic, where any form of task is devolved to the smallest or to the lowest professional qualification that exists. And I personally I don't see the need for a surgeon or radiologist specialists, which are scarce in developing countries, to do any of these things. That should be done by general practitioners, better even by radiographers or nurses.
Yes, and that's exactly why we've targeted the nurses at the Unjani clinics to assist with the screening. Their response following the training, I am enamored, but how they are through using the program, not screening, I see you're shaking your head, but for symptomatic women coming in. There's a very big gap in the education in these rural areas, a very large cultural stigma in South Africa. So most patients tend to err away for any form of treatment. So with the education, it's also assisting for those to actually come. Because this is actually the highest reason for the mortality rates in South Africa. But I agree, it's for those that are symptomatic, not screaming. I agree. Now you're nodding your head. Okay, great. I can't see if someone else is...
Yeah.
Oh.
So I was very impressed by the low percentage of callback because, for example, when you use MRI, you often do biopsies for just not suspicious enhancement, which eventually is a benign thing. And I really hope your development will improve our abilities in evaluating the extent of disease of lobular, which we have a significant problem in clinic.
Yes, and that was exactly where the initial interest started. So the algorithm, as it currently stands, it's able to predict the histological subtype, and its accuracy rate is 97.6%, in comparison to histology, which remains the gold standard and will remain that. But it helps with a better prediction of the histological subtype.